Okay. So thank you again, Zawadi, for that introduction. My name is Yemi Muloni, and I'm a psychologist here at Busani. I will be presenting this case alongside Dr. Pauline Nganga on a real-life example of the effects of ACEs on the quality of life of an individual. Okay, so ACEs is something that is known to us, and it can be described as a wide range of traumatic events that happen before the age of 18. Yeah, this could include emotional abuse, mental health problems, family incarceration, separation, substance use, and physical and emotional neglect, according to Felitti et al. ACEs often are a predetermining factor to the quality of life of adults, and this makes them very vulnerable to a number of health conditions. Okay, so this is a pyramid by the CDC on the effects of ACEs along the life cycle of an individual. And at the bottom there, we can see the historical trauma. And this is the trauma that is usually presented in the caregivers, in the parents, especially when it's not resolved or dealt with. This trauma tends to affect the quality of caregiving that they give the children who they're taken care of. Okay, this then leads to or is also another predisposing factor to the ACEs that people experience is also the environment. So environments that are very vulnerable, this is where there's a lot of neglect or where there is a lot of hostility, tends to be make an individual prone to experiencing ACEs along their life. Okay. We have now the advanced childhood experiences. And this are a wide range, like we had discussed, which involve a lot of the abuse. The experiences could be physical, this could be emotional, this could also be sexual, right? There's also the neglect, which is also another, experience that tends to have significant traumatic events on a child. So this could be emotional neglect. This could also be physical neglect where their parents or their caregivers are not available. Household dysfunction is also another form of, as another ACE that is often experienced, which could include, parental separation or divorce, or when there's substance use within the household that the children are in. Okay. Mental health is also another ACE that creates a lot of household dysfunction, as well as parents being incarcerated and witnessing a lot of domestic violence and abuse within the household. When a child experiences this or is privy to these experiences, they now develop or rather have disrupted neurodevelopmental stages. So it really disrupts a lot of how they learn, right? Which could lead to a lot of social emotional impairment as well as cognitive impairment. So they start growing up struggling with relationships and managing their emotions, their learning, their memory. A lot of these things now are impaired due to this experience. It has also been found that ACEs can alter the brain structure and functioning of individuals because of the kind of stress response that they are constantly being exposed to. This then leads to the social, emotional, cognitive impairment, right? So because of now the disrupted neurodevelopmental stages that the individual has experienced, the way in which they socialize, the way in which they understand and have emotions presented is now also altered, which means they have difficulties with social skills. So their interactions with people, their interactions in social situations are also affected and are often dysfunctional, right? They also tend to have a lot of emotional dysregulation. So they don't know how to manage the emotions that they're experiencing. And this often leads to anxiety and depression, among other mental health issues. Cognitive deficits are also there, right? Because we talked about how the stress response affects their brain. So learning, memory, problem solving, all of those are also affected, right, by experiencing these ACEs. Next is adoption of risky behavior, where as a way to cope with some of the emotions that they are going through, or some of the experiences they are going through, they tend to pick very, very unhealthy coping mechanisms, which often are risky, right? So this could include substance use, this could include very risky sexual behavior, this could include engaging in toxic relationships, things that generally damage their quality of life. This, even how they eat, even how they take care of themselves, right? Depreciates their quality of life over time. Because of this risky behavior, we now are prone to the diseases and disabilities and social problems that they experience, okay? So this now is all health problems, from chronic diseases such as heart disease, cancer, diabetes, and other chronic illnesses to mental health problems, right? Like depression, anxiety, and PTSD. There are social problems that also are affected, such as, their homelessness, they tend to be unemployed, they tend to also interact a lot with the criminal justice system. And because of these problems, this often leads to early death, especially when not mitigated. So the theoretical framework we are using is the internal family systems approach. And this is an approach that is often used to deal with trauma. It is based on the idea that we have all these parts of us that have been fragmented over the course of our lives due to the traumatic events we have, right? So leaning a bit into also some of what the psychodynamic approach has, where there are stages of our lives that are interrupted, especially when we experience trauma. And the main goal of this form of therapy is to ensure that the true self, which is a component of or a part of this, the whole person, right, is given leadership, right? And every other part that has been created because of the traumas that have been experienced can also be heard and seen, and therefore this system can now start working harmoniously, right? Because a lot of now what happens is when these parts are created, they tend to really, really have a lot of internal conflict, okay? So some of the main parts that are recognized in this approach is the inner child, right? This is the part that is there below the age of 21. Then we have the exiles, and this is the parts that are usually sidelined or put in the corner or pushed out of consciousness because they experience a lot of those traumatic memories, and they are the ones that carry that pain and the emotions of those traumatic events. So they are usually put out of consciousness, okay? Then we have the managers, which usually appear as a mitigating part to almost protect and deal with those difficult responses. And they're meant to be protective, so they tend to be very rigid, they tend to be very self-critical and perfectionistic, right? But their goal is just to manage a lot of what the exiles have experienced. Then we have the firefighter role, which is the reactive self, and this one appears immediately when the exiles are created, right? And their main goal is to numb and distract the intense emotions. So theirs is just to find ways. They tend to be very impulsive. The firefighter parts are very impulsive parts. So they're the ones that will do anything possible to try and ensure that the self doesn't experience some of these the intense emotions that are created by the exiles. And then the self now is the core part of the individual, right? And this is the one that is ideally empowered so that it can help mitigate these other parts. It's the one that is meant to take leadership. It's the one that's meant to create a harmonious relationship with all of them, and ideally should be in charge. So one of the internal conflicts among the parts, and that's now when people are coming in to get help, is internalized aggression. So this happens when you are very angry with yourself and you're lashing out at yourself, right? So, and the idea is this is created by the fact that an individual is not allowed to be angry as a child. So it manifests in a lot of self-harm, it manifests in a lot of self-criticism and even suicidality, but that is a lot of attack on self. Okay. Then we have the shame component, which comes from the belief that one is damaged or, unworthy of love or, doing good things or receiving good things rather. And this comes from the neglected and hurt part that has been shamed as a child. Okay. We have the regression part. This part is also categorized by, the extreme emotions that take place, that an individual has, and the fact that usually there's, not appropriate ways to deal with that, so people are throwing tantrums as adults because they have not quite dealt with, the inner child that experienced some of these emotions and going back to that stage, okay? The perfectionism, this is also taken charge by the manager part, which, trying to ensure that people see you as perfect, ensuring that, there's no room for error. There's the contradictory thoughts and feelings, what we often call incongruence, where how you feel and how you are, sometimes there's a disconnect, right? And you can see that these are the parts that are really having conflict within each other, okay? There's the inner critic and saboteur. So this is the inner voice that constantly criticizes and undermines the actions and decisions you are making. The procrastination part, which is the part that avoids a lot of the tasks that you have and, avoids you going forward and, almost sabotages a lot of your progress, And then there is the feeling stuck and indecisive. So this is when you have a difficult time making decisions and advocating for your own opinions, right? And this often creates a lot of confusion. Yeah. And this is now what is seen. These are the conflicts that are seen when a lot of those internal parts are not agreeing or are not in harmony with one another. So our case today is of XY, who is a female in the late 20s. She's not married, and we were managing her with Dr. Pauline. She came into the hospital presenting insomnia, suicidal thoughts, rumination or ruminating, experiencing flashbacks, and was having a lack of appetite on top of uncontrollable crying. So the background of why these symptoms happened is that XY witnessed, right, a forceful eviction. And this was a forceful eviction that happened from her family home, unexpected, right? And this created a lot of shock and embarrassment because this was not something that they had anticipated. They didn't have arrears. So it took them by surprise. And this was also done in full view of all their neighbors, right? And this is a family home. So these are neighbors that they have known for a while. So those were the main things that also she was experiencing during this incident. Now, in the background of that, XY had gone back to work and was put on probation, right? Which she was also unexpected, but she also felt that that was an ambush, right? And she was also living with her parents. And now this family home, she's living with her parents who have a very hostile relationship with each other. And that was that was really, really dysregulating her because of how emotions are very high. There's a lot of tension. There's constant arguments, and having to witness that or intervene or be in the middle of that was also quite stressful over time. Yeah. So this acute stressor was activating that deep-seated survival part, which is shaped by years of trauma, including the inner exiles, yeah, carrying shame, helplessness, and grief, which we had talked about, right? Now, when we walked down the road and when we started evaluating a lot of what she had gone through, we realized that there were a lot of incidences that had happened to this breaking point that she experienced when the eviction happened, right? So first of all, XY is a firstborn, which means that she is the one who had to grow up and be responsible for a lot of her siblings. She has two siblings who are younger than her. So what she experienced was a lot of parentification. And this is because her father was also absent, given that he was working and also an alcoholic. So she had to now develop parts of her that were very, very responsible to control all of that chaos, right? The hostility that she experiences even now was there even when she was younger. So it was also very, it was a lot of intense emotions that she grew up with at home. There's also a strained relationship she has with her parents, right? So very distant or dysfunctional relationship with her father, and with her mother, there's a lot of hostility. So she grew up being very afraid of her mom because her mom was very, very strict and almost to the point of verbally abusive. Both of them were. So there's a lot of insults being exchanged in the house, right? And she grows up with that. At some point when she's, trying to look for a job, or later on in life, when now she's finished university and she's looking for a job, she had to really experience a lot of that, right? Because there's a lot of shame that is being put on her. There's a lot of blame. There's a lot of being compared with her siblings, or being, just a lot of expectations that are being put on her, right? Which created now a lot of that, internal critic, right? She also felt very invalidated, right? There was also an incident where there was an attempted sexual abuse, and she tried to raise an alarm, telling her mom, and, the mom was not as responsive or didn't believe her, right? So a lot of invalidation, right? And then we have the loss and disenfranchised grief, which happened because when the, ex-wife was 5, she actually lost her sister and, was told about the death, didn't get to attend the funeral, didn't get to even discuss or, find out what happened. It was quickly, moved over. They didn't even give her time or go through any form of awareness of what could have happened and how she's feeling, right? To date, it's not something that is talked about, right? But it's something she really, really felt, because this is a sibling she was conscious of, right? I didn't even get to attend her sister's funeral, right? And so it's something that has never been talked about. Even if it's brought up, they see pictures, it's quickly brushed over and silenced, which now has created a lot of the loss and disenfranchised grief, which we'll later see it keeps coming up, right? We also have the sexual boundaries violation, which happened because one of her dad's friends, who she considered a father figure, an uncle, attempted sexual abuse, and that this is happening now in adulthood. So, and another incident where she was also sexually abused in an intimate partner relationship. And these are protector parts that now are being activated, right? So we talked about the firefighter, they've talked about the manager coming in to try and mitigate that risk, but it also has affected how she, trusts people. It has affected her ability to be vulnerable with people. You can see it's boundaries that are very, very, very dysfunctional, right? We also have now the repeated abandonment and attachment wound, which has come about because of, okay, the patient wasn't very close to her mom growing up because of the dysfunctional relationship they had. So when she eventually grew up, she found another maternal figure, right, who also had a son. And she really connected with them and formed a deep attachment with them. But later on, the maternal figure ended up passing away. And a year later, the friend or the son also passed away. And this has also caused a lot of abandonment and has illuminated a lot of the loss that she has experienced, right? And the isolation that she has experienced. So this is the inner child. This is the inner child which has now been left to deal with another grief and another isolation. Okay. So how has this affected her over time? we'll start off with her physical health, right? She has had surgery or underwent tubular surgery in 2019 due to respiratory issues. Yeah. She's also underweight, and that is something that she reported has constantly dealt with, as well as consistently has low blood count, right? So these are some of the effects of over time experiencing some of these stressors. We also have the social functioning that has been impaired, where she doesn't have clear interpersonal boundaries with friends, where she reported giving a lot to her relationships and not getting quite as much back on, what she therapy. She also has unhealthy romantic relationship patterns, yeah, which was brought out especially during the family therapy sessions, where she gets into very toxic relationships with people who are not very, are not present or are not as supportive of her. Yeah, so they end up also taking more than they give. PT has also been in her role. So she got a job and has been in her role for the last 12 years, right? Same position, same job, right? For the last 12 years with no, with no movement, either looking for a promotion or moving elsewhere. It's now, because of the stress that she's experiencing at work, that she's now considering a change, but has been in the same role, same position, her whole life. And this is probably a part of now the concept of the manager role, which comes in to try and mitigate risk and is very, very rigid to ensure that all stability is maintained and a lot of her underlying fears are not, activated or triggered. Okay. We now also have the neurobiological and emotional regulation impacts. So she has a lot of mood fluctuations, right? So sudden mood swings, moving frequently between depressive episodes. She has severe PMDD, has a history of also suicidal attempts, and experiences anxiety attacks, especially when she's in close spaces, right? She also isolates quite a bit despite wanting to spend time with people. And that has also affected how she relates with people, affected how, just a general overall, emotional dysregulation that is taking place. And you can see that now this is the inner conflict that is happening between protector roles and exile roles within that internal system. Her predisposing factors, right, to a lot of what she experienced is her relationship with her mom, the hostility, the neglect she experienced, right? So the hostility from her mom, the neglect she experienced from her dad, right? Her personal history of sexual abuse, especially with the relatives who attempted to sexually abuse her, that also is a predisposing factor. The fact that she wasn't also allowed to grieve, is also another predisposing factor, because it means that grief is disenfranchised, is not allowed to be expressed and seen or heard, right? Precipitating factors, we have the challenges she has at work, especially with her probation. So that has really triggered this event, right? She also had the witnessing that eviction take place, also was a big, big trigger for, her now needing or seeking out or reaching out for help, right? Distress also with intimate partners, that is also another factor that also contributed to her coming in. Her perpetuating factors, there's a lot of limited support and isolation. This is from friends, this is from family. So they're not as present or as there for her because of the way she has created those relationships and the boundaries she has. She also has problems related to her living situation, where the hostile home environment is not particularly conducive for her. Her main protective factors are the fact that she has a stable job, right? So regardless of whether or not she's on probation, at the very least, she has that right now. And she has a good relationship with one of her siblings, right? So that has also helped, is a key protective factor. Most of the interventions that we did were to manage the symptoms she was experiencing. So a lot of CBT was used to mitigate a lot of that. For the emotional dysregulation, we used a lot of the DBT to help with just trying to find balance, trying to ensure that those emotions are expressed, and learning how to do so. And narrative therapy was used to allow her to express some of these unresolved thoughts and memories that she had repressed over time. Family therapy was used mostly for psychoeducation, just to find out from the family what their experience has been, but also to educate them on what she has been dealing with and to find resolution on our way forward. Pharmacotherapy, I will allow Dr. Pauline to share on that after this presentation. So most of the literature reviews that on ACEs showed a relationship between adverse childhood experiences and the presence of long-term conditions. So
it's 9 hours.
The more ACEs you have, which is also now another finding, the more ACEs you have, the more likely you are to experience a lot of these long-term health conditions. There's also another study that found a correlation between ACEs and mental health problems such as depression and anxiety. And this is, it didn't matter whether the gender or when you were exposed. As long as you had those adverse childhood experiences, you are very likely to experience a lot of the mental health conditions. So I would like to stop there and allow Dr. Pauline to share her feedback. Thank you.
Okay, thank you, Moroni, for that. Well, good morning, everyone. So I was the psychiatrist on board for this particular patient. Moroni has talked and covered quite a bit. Now, maybe I should just go back just a bit and add the poor relationship with her mother also stemmed from the fact that, being the firstborn, the mother blamed her for being the one who made her get married to her dad. So that was also something that we were addressing in therapy. And also she resembled her father. So that was also a trigger that kept making the relationship worse. Now, regarding her father, despite him being an educated man with a good job, after O-levels, he refused to pay her college fees. So at some point in time, she had to work as a house help to just manage herself and also to contribute to the family budget, because the father was an alcoholic and rarely spent time at home. Now, why did she move back home? She moved back because the abuse or the violent relationship between her parents continued way into the years, and it became worse when the patient moved away to live on her own. So actually, she thought that by moving back home, her parents should be able to kind of control that violence, and maybe daddy would see her home and decrease the hostility towards her mother. So she also went back home to be able to settle her parents down. So one of her biggest problems was, maybe if I go back home, I'll be able also to talk to dad, and they'll be able to build a house and probably move out of town, whereby she will not have to deal with the rent issues, rent arrears all the time, because she's the one to date who who pays rent for her parents. So that was just in addition to what Yemi talked about. So in her medication, one after the lab results, we realized that she had exactly what Yemi was talking about: low blood count, low HB levels, that is low hemoglobin levels, because of her poor diet. So one of the things I did was add an hematinic, ranferon for that matter. For the, I added quetiapine because quetiapine is good for insomnia and also for depression. It has been found good for depression. So I started her on a low dose quetiapine, 50 milligrams at night, but later I had to increase to 100 milligrams at night when she was noted not to be sleeping well. The antidepressant I chose was mirtazapine, just due to the fact that also mirtazapine is very helpful when you want to target sleep in a depressed patient. For anxiety, the immediate to help her relax immediately, I just put her on a low dose of alzolam, which worked well, and she was able to relax and gain her, let me say, she became happier at some point. Later, we still noted she was a bit tearful, especially when she started the therapy sessions with Yemi, when they went deeper into now the conflicts at home and the triggers. She became very tearful, and I had to add lamotrigine because lamotrigine is important as a mood stabilizer and also is good as a mood stabilizer, especially where there are suicidal ideation and thoughts. It is thought to decrease suicidal ideation. So that was the pharmacology. We did a vitamin D level test, and vitamin D was low. So again, we just supplemented vitamin D in addition to all the rest. So that was my input as a psychiatrist.
Thank you very much, Dr. Pauline. At this juncture, I want to usher us into the Q&A section. And there is a question that has been sent on the chat box here that I'm going to read out. And I'd like Yemi to take it first, and then maybe you can give further comments around it. And the question reads, what is the role of culture in shaping how ACEs are experienced, interpreted, and treated, especially in communities where certain adversities may be normalized or go unrecognized as harmful, such as poverty, being orphaned and lacked within the African context?
Okay, thank you for that question. So culture plays a pivotal role in the expression and suppression of ACEs in many African contexts. For example, what may be classified as emotional neglect or verbal abuse in Western cultures, ACEs frameworks can be normalized, as discipline or tough love, right, in now African contexts, right? This normalization can delay help seeking and even lead to intergenerational trauma transmission. And, under the guise of, survival, So moreover, cultural norms often prioritize family honor, there's, resilience, there's discipline, which can suppress conversations around things like parental conflict or mental illness, even sexual abuse, right? And this means many individuals internalize their suffering and interpret it as personal failure rather than a trauma response. So we need to approach ACEs through cultural adaptive lenses, right? So that's knowing our culture, the Western culture, and what is actually considered an ACE. And this includes validating local contexts, using languages that doesn't pathologize, and incorporating indigenous frameworks for healing, like local or community rituals, storytelling, even spiritual support, right? Alongside, evidence-based care like psychotherapy and, psychiatric care. Yes, I think that answers that question.
Dr. Poli, do you have any additions as to this particular question?
No, I think Amy has captured it well, and I'm satisfied. There's nothing I can add.
Okay, now there's a question that is more for you. How do we ensure that we rule out all possible organic causes and diseases and disease processes that may not be related to mental illness? For instance, was the anemia investigated? I think, yes, you did mention it was. And all possible causes ruled out for this particular client, like, other tests.
Yes, we did comprehensive tests. We actually started with a full blood count. Then we did the renal tests. We did the liver function test. We did thyroid function tests. We did lipid profiles. We did diabetic test, HbA1c. We also did VDRL tests, and all were negative. The only important finding was the low blood count and the low vitamin D levels. So I was actually satisfied that there were actually no organic causes, and we settled for PTSD.
Thank you. You've answered that question. And the next question I was going to ask you, which was the diagnosis that you settled on. And there's a follow-up question here. And this one I think would be useful for everyone. How can clinicians differentiate between personality disorders and trauma-related presentations when the symptom overlap is very high, like in the case of this young lady?
Oh, okay. That is captured when one takes a history. So with this, with the history we took with Amy, actually we took it from childhood experience, that is from birth to schooling, the schooling history. Actually what Amy has captured, the birth, the schooling history through primary, through secondary, and through her tertiary education. And you find that she was okay. The only problem was the kind of experiences she was having at home and also the trauma she experienced in school, because they were caned thoroughly while in school. So her work, her personality was consistent with a very balanced girl who had tried to cope with all the difficulties she had experienced as a child. So when we did not pick out any personality disorder apart from the kind of adverse childhood experiences she had. So we can say that with this case, we were certain that there was no personality disorder because she looked presentable, she expressed herself well, her judgment was good, her abstract thinking was good, the way she carried herself, we observed her in the ward, she was okay. And even from the relationship between her and her sisters, we could see that she was somebody who was warm, she had acceptable, let me say, social interactions. Her way of dressing, all this did not point out to any personality disorder. Now, that is when we settled for PTSD, because now with that, we related her history and her current presentation. And it fell in line with what we call a post-traumatic stress disorder, because the reason she came for admission was she had a re-experience. When goons came to their house to attack them and to throw them out, that is when actually that was a trigger. So that was in keeping with the kind of abuse and experiences she had had as a child. So through history taking, we did not pick out any personality disorder.
I think I agree. I agree with what Dr. Pauline is saying. Also, when you manage a lot of the symptoms that have arisen, sometimes because of the overlap, there's an overlap in symptoms between, traumatic disorders and also personality disorders. But once you manage a lot of those symptoms, I think it tends to be very clear that we are actually not dealing with a personality disorder, but traumatic, an experience of trauma disorders. Thank you.
Now we have another question here. And it's more in the lines of patients having like extremely low weight. And the question are, were there any physical indications of anorexia nervosa or like eating disordered type of psychological psychopathology? Dr. Pauline?
Okay, yes, we assessed that actually, and we realized that her eating habits were quite normal. She just had poor appetite, and that was due to the environment at home. She actually confessed her mother is a good cook, and she enjoyed her mother's meals. But I think we related it to the stress she was experiencing at home, especially when there are always issues to do with the parents that interfered with her appetite. She did not even have comfort eating, as experienced by many depressed patients. So, and she was willing to gain weight. We were concerned about her weight gain, especially when I prescribed quetiapine and mirtazapine. And she said, "Doc, I have no problem with weight gain. I even wish to gain weight." So clearly there was no anorexia because she had not reached the critical weight for diagnosis of anorexia. And we did not pick out any bulimia nervosa, any symptoms suggestive of that, of either.
Now, interestingly, it's like you are reading the questions as I ask them, because right next to that question was the question, except sleep, what was another reason for giving quetiapine? Was her weight one of the things that informed that particular clinical decision?
One, her weight, she was not big, she was kind of small. Number two, quetiapine is also important for depression. It has a role to play in depression, and also it is good for sleep. It's good for managing insomnia. So she actually had what it takes to give quetiapine. One, she was depressed. Number two, she was insomniac. And number three, she was not obese. So it was safe to give her that. And I think I discussed the side effects with her, and she was okay, because the main side effect with quetiapine is the weight gain, especially the immediate release formulation. With the sustained release formulation, the weight gain is slower as compared to the immediate release formulation, which I prescribed for her, because it's also good for managing the insomnia and the depression she was experiencing.
Okay, now there's a comment here that I must read. It's from Hendrix. It reads, CPTSD, bipolar mood disorder, borderline personality disorder, PTSD are all implicated in ACEs. CPTSD lacks flashbacks that PTSD has. CPTSD and PTSD can be comorbid. CPTSD and borderline personality share disturbance in self-organization, but CPTSD lacks identity disturbance. So in his position, he would like us to consider that both CPTSD and PTSD could be at play with this particular client. But now, having read that comment, there are two questions here in regards to different case scenarios. And I will ask the first one to go to Yemi, and then the second one can go to Dr. Pauline, so that each of you has equal distribution of this. So the first question reads, how do you help a marriage partner who has the same symptoms in order to prevent them from passing on the same to their children, especially if they have sadistic tendencies where they derive pleasure from even punishing children? How do you help the children cope from such apparent? Okay, so these are two questions, I think. Maybe we can start with the first one, Yemi, where how do you help prevent transgenerational trauma from a situation such as this?
Okay, thank you for that question. That one is a very interesting one. First of all, it's getting help. Yeah, you come for therapy and we start dealing with the underlying issues. So getting therapy for not only the children who have been experiencing and been in this environment where they're living with an unhealthy parent, but also getting therapy for that parent, right? To unpack some of the traumas that have triggered some of these, you're calling them sadistic tendencies, right? The children also need to come to therapy to, deal with what they are feeling, a lot of the thoughts they have, so that they also understand or have a place to even share some of the concerns and the things they have seen. But also to ensure that they are not repressing, a lot of these things which will later on come up to affect them. So getting a lot of help for both of them, even the whole family, right? So the spouse, the patient, the person who is struggling with the sadistic tendencies, and the children also all need therapy to try and find a way to create a system that now is working going forward. Thank you.
Thank you. Sorry. Thank you very much, Shimi. The next question is also another case scenario, and this one I would like Dr. Pauline to help us out with. What do you do in a case with a person who has ACEs combined with alcoholism? Such a person, when intoxicated, presents with aggressiveness, crying, disinhibition, and no recall of the behavior when sober. The person has no insight and does not feel like they have a problem. What do you do?
Okay, that's quite common. Usually, anybody who has experienced some abuse in their life, most of them take alcohol as a coping mechanism. So, of course, most of the people deny the fact that when you're drunk, there's a lot of behavior that you'll not even remember that you had or you manifested. So I think the first thing is first diagnose that this person has an alcohol problem. And then we take them through the detox. Now, once we do the detox and the person is a bit sober or has improved cognitively with this cognitive function improvement, then you go back and take a deeper history. Now you look for the triggers. What makes you take alcohol? When did you start and why do you take alcohol? Because usually people are running away from something. So now, once the history is going to help you understand the background behind the alcohol, the excessive alcohol use or intake. And that, if you find out that there was any ACE, then that is where you start, where healing begins, because you go back now into therapy. and try to understand again the kind of abuse and take them through trauma therapy. So the first step in this case is probably the patient has been brought drunk, disorganized, confused, whatever it is. Let us start by stabilizing that patient. We do a detox, we put him on medication. Then once he's stable, let us go back into now talk to the patient, go back to the history, understand his alcohol use, look for any and identify any triggers. If there is ACE, then address that in form of therapy. And I am very sure there's going to be a lot of improvement in the patient's life and in the patient's behavior. Thank you.
All right. There's a lot of activity here. I don't think we'll be able to answer a lot of our questions, but I am extremely loving all of the engagement that I'm having from all of you. There's a question here that would be such a shame if we did not answer, and that is, does spiritual support have a place in alleviating such trauma? So this question I'm going to ask you, Yemi, and then Dr. Pauline can support before we start to, wrap up our conversation.
Thank you for that question. Spiritual support often comes in to give meaning to a lot of the experiences that an individual has. So if that spiritual support is there, definitely it can be helpful in alleviating a lot of the traumatic symptoms that an individual is experiencing. It can also help in building resilience, which is an important tool that we try and create with people who are going through trauma. So yes, thank you.
Okay, my contribution to that question is yes, spiritual support plays a very important role. Initially in the model of treatment, in the treatment models, especially for mental health, we had the biopsychosocial approach. But later on, most recent, I think in the 1950s, the WHO added spiritual approach. So now we have the biopsychosocial, and then in addition, a spiritual approach. Why spiritual? Because most mental health experts could not understand or could not respond to questions like, why am I suffering? Doc, if I am going to die, where am I going to go? What have I done wrong? What can I do right to alleviate my suffering? So with that, many did not know how to respond to that question, because that clearly gives us meaning of life, or a spiritual angle to handling many of the cases we come across. So right now, spirituality is regarded as very important. There's a big study in New York. It was done in the early 2000s that compared morbidity and mortality in people who are religious and non-religious. Actually, there was high morbidity and mortality in non-religious and non-spiritual patients, while there was lower morbidity and mortality in religious and spiritual patients. So clearly, when patients ask you some questions and that you cannot answer, especially in regard to their faith and their beliefs and their spiritual orientation, then we actually refer them for spiritual counseling where they feel they will need help. We have patients even who have asked to see an imam. They're in hospital, they are suffering, and they have refused all forms of therapy. But once they talk to an imam, actually you find that they're improving, they are now cooperating with doctors, they are taking their medication, they are happier. And of course, with that happiness, there's a increased, or they recover. The recovery process becomes faster, and the hospital stay decreases. So yes, spiritual angle is very important and has been adapted now.
Thank you very much, Dr. Pauline. What you have said is completely solid and true. Now, because time is really, really against us, I would like to invite a special comment from Dr. Siengo. Dr. Siengo, if you're here, I can allow you to give us a special comment before I introduce Professor Njenga to give his remarks.
Good morning, and thank you for the chance to contribute. It was a very good discussion. So congratulations to who organized and participated. Maybe to just add on the role of spirituality as not what many people think it's about religion. So spirituality is now about being in balance, and that's why it's also part of what WHO has also accepted as part of, it should be component of the treatment. And basically, childhood adverse effects are very common in our setup. And I still feel that we need more people who can even do EMDR. I don't know whether there was a role of EMDR in this patient. Thank you.
Thank you very much. Sorry. Thank you very much, Dr. Siengo. I would now like to, if you'll allow me for just 2 minutes, I'd like to give Dr. Mumbi Chege a moment to comment, especially in regards to spirituality and trauma, given as to the fact that she's very knowledgeable in this particular topic. And then now we move to Dr. Njenga. So Dr. Mumbi, if you're with us, maybe you can give just one comment for 1 minute, and then now we go to Dr. Njenga. Okay. All right. I think then we can move to Dr. Njenga so that you can give us your thoughts around the conversation of the day.
Zawadi, it's 9:30, so I'll say only one thing. I think what Pauline and Yemi have helped us to understand, among other things, is the power of working together. We take it for granted, the Chiromo Hospital group, that everybody works together. The psychologist and the psychiatrist work together. But that is not necessarily the case everywhere. And I think what I will take home from this conversation is that we are better together. The second thing, I was going to say one thing, but I'll say one more thing. It also demonstrates very clearly and very loudly the fact that if you hear what your patient is saying, you have a better chance to get them better than if you don't hear the deeper meaning of what they are saying. And finally, I like the combination of the treatment approaches, which is pharmacological and psychological, and they seem to have had great success. So we are better when we work together. Thank you.
Thank you very much, Professor Njenga, for your insights and inputs. I would like to thank Dr. Pauline and Yemi for a wonderful presentation, really fantastic work. We have seen more of your questions here. We will attempt to address them. We're trying to work on a system that we can address your questions even post the event. With all of these remarks that have been shared to us today, I want us to just remember the impacts of early trauma in the inner workings of PATS therapy and the ongoing challenges in providing care in resource-limited systems. This conversation today reminds us that sometimes everything that can go wrong goes wrong, but that is not the end of the story. And this is something that I borrow a lot from what Dr. Njenga says, that once someone is treated, then even the wrongs that have happened to them and around them can be turned around, and you have a different narrative moving forward. So with these very, very many remarks, I would like to thank you for joining us today and to welcome you to our next grand round. Asanteni sana and have yourselves a lovely day.
Asante. Good day too to everybody.